Good evening all, my name's Anisha Patel, I'm a GP and I've been asked to host this evening. Thank you all so much for joining us on behalf of King Edward VII Hospital. We've got a fantastic panel here tonight who are going to be talking to you about bowel cancer, answering your questions and giving a bit of history and background as to what they all do. We really hope you enjoy the evening, that it's informative and educational. And please do feel free to write away your questions in the chat room on the side. I will be giving a short briefing to my story as a bowel cancer patient, and I'll also be introducing our panel now. We have James Kinross, who is from Imperial College. He is one of our surgeons here tonight, and he has an interest in minimally invasive surgery, including laparoscopic and robotic surgery, and is a researcher into the gut microbiome, which I know is a massive interest to a lot of fellow bowelies that I'm friends with, particularly in the role of the development of bowel cancer. We have Charlie Evans, who is another surgeon here. He's the head of GI surgery, gastrosurgery at Coventry, and his specialist interest is robotic surgery, and he is a researcher in this field and also a trainer. Then we've got Dan Krell, he's our oncologist on the panel tonight, and he specialises in gastrointestinal cancers and will be giving us an overview on all the management in terms of chemo, immunotherapy and targeted therapies that we have. And last but not least, and the most important person, is our cancer nurse specialist, Faye, who is every patient's best friend. And she has an MSc in colorectal surgery, has many years experience, and works at King Edward VII. So what I'll do is I'll just give an overview of my story first. Obviously, I was asked to host this meeting because it's something close to my heart. It's something that since my diagnosis, I've very much been involved in with raising awareness, and as a doctor have tried to bridge that gap between patient and doctor, and being an advocate for both and looking at it from both angles, I guess. And so from day dot, I've tried to raise awareness. I actively do now. I think some of you will have seen me on Lorraine this morning with their No Buts campaign. And I've basically written my journey through all treatment on a blog at Doctors Get Cancer Too, trying to help others, but also as my own catharsis during treatment. I was diagnosed back in September 2018. I think if I'm being completely honest with myself, my symptoms probably started January 2018. I initially felt extreme fatigue, so fatigue more than usual, I'd say. And I went to see my GP, but thought really that it was nothing. I was a busy mum working, long hours, general practice, small children, just thought it was due to my life, burning the candle at both ends. And my bloods at that point were normal. But I did start to have what I considered would probably IBS symptoms at that point. But again, with stress in my life, it wouldn't be unusual. And so it started with constipation. I'd always had sort of piles after sort of childbirth. And with the constipation, I assumed that the bits of bleeding that I was getting on the tissue were piles. And this progressed for a few months. And then in June, I decided to sort of do something about this because it was getting more so. And I was getting some, what I'd probably describe as that feeling where you can't completely empty your bowel. And I spoke to my husband, who happens to be the director of the Bowel Cancer Screening Service, ironically. And I asked him to actually come and have a look and just say, I'm not really sure that this is what it's meant to look like if you've got piles. And he obviously agreed with me. And I went to my GP in July. At that point, I was given we thought we'd do some more bloods, treat with laxatives, and try a trial of Sherry-Proctor treatment for hemorrhoids. And lo and behold, I went away on holiday. Symptoms supposedly got a little bit better, but I noticed that I was eating like a horse and wasn't putting on weight. Again, didn't really think anything of it. But what then started to happen was I would have my poo change shape, so it was thin. I'd get pain in my bottom end, and things just got worse. So by end of August, I went back to my GP saying things aren't right. The blood showed I was now anemic, but I'd been anemic on and off since being a child, but we'd referred to a surgeon. I went down the 2-week pathway, and my surgeon was pretty convinced from his letter that it was functional with piles, and so I proceeded to have a colonoscopy. Probably he was just being extra thorough, in his words, because I was anemic. I underwent my colonoscopy, and lo and behold, I saw my 5-centimetre tumour on the screen, and I went and had my staging CT straight away. Unfortunately, at the time, I was also started to have quite severe sciatica, which was new onset for 7 weeks. And I think in everyone's head, they were worried that it had spread to my spine as well. The CT was thankfully showed no spread to my liver and lungs. But 3 days later, I had an MRI scan, and thankfully there was no spread to my spine either. In terms of lymph nodes and sort of classing at that time, I was classed as a stage 3C, and then proceeded to have a laparoscopic anterior resection with Professor Rectal at the Royal Surrey, and a TME and an ileostomy. The problem at the time is that I was given a choice, and I'm not sure how much of a choice I would have been given in terms of being medics, and there was always that difficulty as a patient doctor through this journey where I think we were given a lot of choice, and I think patients should be given choice, but actually I just wanted to be the patient. I wanted to be told by my surgeon oncologist what the best thing was for me, and the option was chemoradiotherapy before my surgery, but they felt, or my surgeon felt, that he might be able to remove it intact and prevent me, because I was young, having chemoradiotherapy beforehand. So we took a punt and we went for the surgery. And I didn't know whether I was going to wake up with a stoma or him just closing me back up and saying, actually, you need to pop off for some chemoradiotherapy first. But he luckily removed it all. And actually, when the histology came back, I only had 1 lymph node. So I was downstage to a stage 3B, and then went on to have 3 months of Xelox chemotherapy, which is oxaliplatin, and capecitabine. The chemotherapy was hard work. I found it hard work. And, you know, as a result of treatments, you know, there is an aftermath that I think a lot of patients with bowel cancer find difficult to manage afterwards, in terms of the peripheral neuropathy, in terms of LARS, the lower anterior resection syndrome, and the bowel dysfunction that one gets. And I think, you know, even the mental health aspects of going through a diagnosis like this, in a life-changing illness, and living with the uncertainty that something like this brings, especially when you're diagnosed at 39 and you know, people tell you, oh, you're too young to have cancer. I think what's really important to say is that this is a really common cancer. You know, 42,000 people are diagnosed each year, 1 person every 15 minutes. And, you know, 16,000 people die of this cancer each year, and that's 1 person every 30 minutes. So, you know, it's a cancer that really needs to be spoken about a lot more, and there isn't enough done, in my opinion, to try and promote getting people to present earlier, because there is this embarrassment, there is this taboo, there is this sort of stigma about talking about bowel dysfunction. And I often get patients even now coming to me, oh, I'm so embarrassed, doctor, I've been waiting for this for a while. And that's something that we're really trying to break down. So that's my story in a nutshell. I'm happy to take questions about it in the chat if anyone wants to know, but otherwise I will hand you over to James.
Thanks, Anisha. Thanks for sharing that with us. That's the first time I've heard your story, and I have to say, it really resonates with the experience that I have as a clinician on the other side of that fence. And unfortunately, we hear that same story too often. And I think if I have to have one message from what I'm going to talk about, it's to say that bowel cancer is preventable. So if you don't remember anything that I'm about to say, it doesn't matter. All you need to know is that it's preventable. And I'm conscious that many people on this call and listening to this will have cancer, or will have of someone in their family who has cancer, and will want to talk about the treatment and therapy. But I think Anisha's point is extremely important, which is that if we talk about it more, and we raise awareness, we can stop people getting into that position. So I think Anisha mentioned some of the statistics about how common bowel cancer is, and it is really common. It's probably the second leading cause of cancer-related death worldwide. About 1.2 million people are diagnosed with bowel cancer across the world each year. In the United Kingdom, we have quite high rates of bowel cancer because we live in a westernized culture, and we can talk about why that's important in a second. But I suppose the cancer incidence across the board has fallen a little bit over the last decade or so, and that's because we've had better approaches for diagnosis. That is not universal, and it's not the same across all age groups. And I think particularly young people and particularly millennials are at increasing risk. So in fact, actually, if you're a millennial, your risk of bowel cancer, and particularly rectal cancer, is now 4 times that of someone who was born in the 60s and 70s. And there is a disproportionate rise in the incidence of bowel cancer in young people. And it often gets misdiagnosed and mistreated because it's put down to hemorrhoids, exactly like you've just been told. It's thought, oh, it can't be cancer, you're too young, and that's not the case. So it's a common cancer. If you catch it early, it's treatable and it's completely preventable, and you must not be embarrassed about having symptoms, and you must see your doctor. So how does it typically present? Well, if we look across the board at all cancers, probably around a quarter of bowel cancers will present as an emergency. So the patients will present with abdominal pain or symptoms of really advanced cancer, and they will typically present to the emergency room or to the accident emergency department, or they'll present to their doctor, really usually quite unwell. And usually they meet someone like Charlie or myself, and we end up having to sort out their problem on the back foot. Many people are also completely asymptomatic. They don't have any symptoms at all. About half will probably have many of the similar symptoms that Anisha described. So typically a persistent change in bowel habit. All of our bowel habit fluctuates a little bit. As we get older, our bowel habit changes. But if you're having a sustained change in your bowel habit, either towards looser bowel motions, or you're going more frequently, or conversely, you're finding yourself constipated and you're not going as much as you probably should. If you're noticing that you're passing blood, particularly altered blood, so dark blood, and that is not getting better, it's sustaining and it's not going away. Or if you're having a feeling of incomplete bowel evacuation, so you sit on the toilet and actually you open your bowels and afterwards you feel like you're not quite empty and you've got to go back. These are all what I would call red flag signs, they're warning signs. And if you have those, you need to see your doctor, and your doctor will refer you into a hospital. In the United Kingdom, we have a national screening program. And if you're between the ages of 60 and 74, you may be asked to perform a test at home. And that test at home is based on the measurement of blood in your feces. Because if we can detect blood, there's a chance that you might have a bowel cancer. That chance is actually pretty small. The important bit about that test is that if you don't have blood in your feces, it's very unlikely that you have bowel cancer, and you can be reassured. And typically you'll be asked to do that test every 2 years. If you do that test and it's positive, you may be asked to come and have a colonoscopy, and you heard about Anisha's experience there. So that's a telescopic examination of the bowel. Sometimes we do it with you asleep. Most of the time we do it with a little bit of light sedation, sometimes no sedation at all. And that is the gold standard way of diagnosing bowel cancer, with a camera test where we can take a tissue biopsy. Not everyone is suitable for a telescope test, either because they can't tolerate sedation or because they're frail. And increasingly, we're also doing CT scans. We do a particular type of CT scan called a virtual colonoscopy, where we put a little bit of air into the bottom and a little bit of contrast, and it allows us to get a very fine image of the bowel, which we can cleverly reconstruct into 3 dimensions, and we can detect even quite small polyps with that process. And increasingly, patients are also diagnosed by this modality. In the event that you are diagnosed, the next objective is to try and work out if that cancer has spread from the bowel to outside of the bowel. And typically we do that with scans. So again, you heard Anisha talk about having a CT scan or a CAT scan, but we also do other types of scans like MRI scans, and occasionally even advanced scans like PET scans. And our ability to really precisely stage cancer is getting better all of the time. Increasingly, we also look at the biology of these cancers. So we look at both their genetics and their histological features, which means we look at it under the microscope and we try to see what type of cancer it is, because not all bowel cancers are the same. And quite often we try and stratify treatment based on the biology that we're finding. If you are diagnosed with a bowel cancer, typically you get managed within something called a multidisciplinary team. Actually, we pretty much got an MDT on this call today, which is brilliant. But an MDT is a collection of specialists that look at your case holistically, and they look at every aspect of your case. And it's very important that we have your voice in that meeting. And often Faye will be the person representing your voice if you come to our MDT. And we look at your case and all the best available evidence. And upon that basis, we then make a decision for treatment. And it's usually at that point that we're able to then have that discussion about what happens next. So in the short time I've had to speak to you, I've taken you through just a brief part of Anisha's story, which is the common presenting symptoms of bowel cancer, how it's typically diagnosed and where it's typically diagnosed, how we make decisions. And again, there's one overriding message, which that bowel cancer is preventable. If you're embarrassed, go and get checked out. It's not a big deal, and we'd be really happy to see you at any time. Probably at this moment I will stop there because I've talked for quite a bit, and I probably will hand over to my colleague Charlie. Is that a good idea, Charlie? You're probably muted though, Charlie.
Your usual technology genius. Hello, yeah. So my role is to talk about the surgical treatments for bowel cancer, the bit that Anisha mentioned about an anterior section, which to us medics sounds like we all know what we're talking about, but if you're not medically minded, it means removing the lower bowel, the rectum, and trying to join the two ends back together again. And the decision on surgery is quite a complex one, but I'm as a surgeon, often the time I meet the patients is when they've already had all these tests, they've got a diagnosis, and they're usually walking into a room pretty terrified, and they look at me and they kind of, what they want to know is, can you treat me? How are you going to treat me? And am I going to need a bag? That's usually what I get. And that decision, it's obviously, I'm part of the process of making that decision with you, the patient, but also, as James has mentioned, that's discussed at an MDT, a big team meeting beforehand, where you've got specialists who look at the imaging to see how advanced the tumor is. You've got surgeons who look at like sort of challenges about trying to do the operation. And you've got the oncologists who think, well, maybe actually we might need to give some additional treatments first before we even offer them surgery. And sort of the factors that we're looking at are factors about the cancer in terms of where the cancer is in the bowel as to what operation we can do, factors about how advanced it is, because if it's an early cancer, we might not even need to do a big operation. We might be able to remove it endoscopically. But if it's gone beyond the bowel wall and it's spread to another organ, you might need a thing called an exenteration, where you take more than just the bowel out. And so again, you need experts to be able to diagnose that for you. And then, so there's the cancer factors, there's the patient factors, there's things about, is the patient going to be fit enough for an operation? And this is where, as we talked about Faye, people who've seen the patient, have got an understanding of their medical history, know whether or not, it's going to be amenable for them to go through a big operation, because any of these operations are big operations. And with that, we're already starting to think about, well, how can we do this surgery? And if a patient's already gone through lots and lots of operations beforehand, that's going to influence our decision about what we can offer them, because it gets more and more challenging the more surgery you've had. And then finally, the final factor is is the surgeon themselves. They've got to be comfortable with what they're doing when they're offering you surgery, because the principles we have when I meet a patient is, I've got to be able to know that I'm going to do, number one, a safe operation, and number two, remove the cancer. Remove the cancer so that they have a good outcome immediately, but also you reduce the chance of them getting recurrence at a later date. You want to make sure that when you're doing that, it's going to be a big insult on the patient. You're going to take a big specimen out of their body, but you're going to try and minimize the trauma to them, and and you're trying to work out the best way to balance that. Because the options in terms of doing this surgery is either doing it as an open operation, which is the traditional and still the gold standard way, where basically you make a big cut in your tummy, either up, down, or across, usually up and down, or now, and increasingly frequently across the UK, you do it minimally invasively, which is either keyhole surgery, which is sort of laparoscopic surgery, or as we offer here at King Edward VII, and over 30 centres in the NHS now do, is robotically. And what we mean by laparoscopic or sort of keyhole surgery is that as opposed to making a big cut down the middle of your tummy, you make several small cuts where you can put sort of instruments inside the body, mobilize the bowel, free up the bits that need to be taken out, and then resect them without making such a big long cut, which hopefully reduces sort of the stress on the patient body and minimizes the trauma they have, and hopefully improves their recovery in the short term. In terms of what operation you're going to do, as I said, it depends on the site of the operation. If you have a colon cancer on the right side, you're going to have to remove the right side of the colon. If it's in the middle and the transverse, you might remove all of the right side or the left side. It just depends slightly where it is. The sigmoid colon, again, is the sigmoid, the S bend, and that, again, you do a colectomy. Hopefully, with most of these operations, you can avoid needing a stoma bag, but on rare occasions you might, but basically you're trying to just join the two ends of bowel back together again. And again, it can be done either as an open operation or as a keyhole operation. It gets more challenging when you're doing surgery on the lower bit of bowel, the rectum. And the closer the tumoral, the growth is to the bottom end, the harder it gets to get below that tumor, because you've got to get all of that tumor out. And also, not only have you got to get all of the tumor out, but you've also get there's a fat wrapping around the rectum called the mesorectum. And there's clear evidence that if you preserve all of that and safely remove it, you reduce the risk of getting recurrence. And if you can do that safely and get below it, you can hopefully do a join without the need for stoma. But the lower that join is, the nearer to the bottom hole it is, the more likely there is that join won't take. So a lot of patients, I think like Anisha, do end up needing an ileostomy just for a period of time while that join heals, just to make sure that if there is any complications from the join, it doesn't leak and it doesn't cause complications and contamination in the pelvis. Unfortunately, there are some patients where the tumor is so low, it's so close to the bottom hole that it's just not safe to try and, because we're trying to remove the cancer, we have to take the bottom hole with the rectum itself, and then we end up doing a thing called an abdominoperineal excision, where we have to take all of the lower bowel, including the anus, out with it. So you end up with no bottom hole. We then bring up the bowel upstream as a permanent colostomy. Now, my passion is robotic surgery, which is keyhole surgery. And why I'm passionate about it, because I think it adds the good elements of open surgery with the good elements of laparoscopic keyhole surgery. See, the benefit of open surgery is that, you know, lots of surgeons have been doing it for a lot of time. We're all very familiar with it. And there are surgeons across the UK who do an amazing job doing open surgery. However, you need a big cut to get in there. And if you're like me with size 8 hands, you need a big hole to get in. So to do that, the real benefit is, though, you have your hands inside the patient. You can feel where the lump is, and there have been studies to show that you get a really high quality specimen if you do an open TME, whereas with a laparoscopic one, which is a keyhole one, you have the benefits of not making a big cut and just doing it with chopsticks, but it is incredibly difficult to get down into the pelvis to take out the lower bowel, and these same studies that showed how good the open surgery was questioned how easy it is to remove these bits of bowel laparoscopically, and the quality of the specimens may not be quite as high end as those done openly. Now, the benefit of the robot, because I don't think I've got too much longer left to talk about, is the fact that we have precision high D3 definition keyhole surgery. So you can see what you're doing, but you also have articulated instruments. So it's like having little hands inside the patient. So you get the benefit of doing it minimally invasively, so you don't have the big cuts, but also the precision of seeing exactly what you're doing, and these hands that you can get up around these little joints. So in summary, the decision on what surgery you need is really dependent on a lot of factors. What's wrong in terms of the cancer you have, and what the challenges are as you as a patient. We're increasingly getting younger and fitter patients, as James has mentioned. So more and more we're trying to offer them advanced, minimally invasive surgery so they can recover quicker and get back to their quality of life. And but the beauty of the UK and the treatment you'll get here is that there is really good training, really high standards, and whatever sort of technique that's offered to you, there will have been an MDT discussion to make sure that it's the right surgery that you require. I think I'll finish there. And I think it's Dan next, I believe. Is that right?
Thank you.
Thanks, Charlie. So I'm going to talk about what I do, which is drug treatment, essentially, for bowel cancer patients. And I give drug treatment mainly for three reasons. One is in what we call the neoadjuvant setting. So that's to downstage a tumour to allow an operation to take place. Adjuvant chemotherapy, so that's chemotherapy after surgery to reduce the risk of the cancer coming back. And then giving chemotherapy treatment or other drugs in the metastatic setting, which is most often aimed at improving patients' symptoms and prolonging survival. And there are lots of new drugs that have emerged over the past 10 years or so, but the main backbone of treatment remains chemotherapy. In the adjuvant setting, so after surgery, it tends to be either one drug or two drugs, and that's dependent upon the stage of the tumour. So in stage 2 tumours that are removed, we would offer single agent chemotherapy, normally with a tablet called capecitabine. And in patients where lymph nodes are involved, we would give combination chemotherapy with oxaliplatin and either an intravenous drug called 5-FU or a tablet called capecitabine. There are some slight changes to that depending on the genetics, which I won't go into, but that's generally what we would do. What does chemotherapy offer in that situation? Well, it's a risk reduction in terms of recurrence. So patients have had a good operation to remove all of the visible tumour, and chemotherapy in that situation is aimed at treating any what we call micrometastatic disease, so disease that we can't see on scans, that may be there, that we want to eradicate before it can grow into a tumour. And depending on the stage of the tumour, the reduction in risk tends to be between 3 and around 15% risk reduction by giving chemotherapy. And that tends to be between 3 and 6 months of chemotherapy treatment. In the metastatic setting, like I've said, treatment's aimed at controlling the disease, improving symptoms and prolonging survival. And the mainstay of treatment is chemotherapy, but treatment's guided by some of the genetic tests that we look for in a tumour. The main ones that we look for are something called mismatch repair, RAS and BRAF, and those can help to direct which treatments we give. The backbone of chemotherapy is either a combination with oxaliplatin or irinotecan. And we would generally add an antibody therapy depending on the genetics, either a drug called Avastin, which works on blood vessel formation and growth factors, or an EGFR inhibitor, drugs like cetuximab or panitumumab, which block some of the antennae on the surface of cancer cells that have been developed to help them to grow. And that's dependent upon the genetics of the tumour. More recently, we've developed combination therapies for patients with BRAF mutant tumours. Now, BRAF is a mutation that tends to confer a more aggressive tumour biology. And we would tend to use a triplet combination of chemotherapy in the first line setting, and then an EGFR inhibitor and a BRAF inhibitor, drugs like encorafenib and cetuximab, to treat those tumours. And more we're being asked about immunotherapy treatment, because immunotherapy treatment is in the news a lot and has been a game changer in many different tumour types, particularly tumours like melanoma and lung cancer. And it tends to work better in tumours that have a higher tumour mutational load, so a greater number of genes that are damaged due to things like sun exposure, hence in melanoma, or smoking, hence its use in lung cancer. In bowel cancer, immunotherapy is only useful in probably around 10% of patients. And that's in patients who have a deficiency in mismatch repair, or more recently, another gene called POLE, which is more common in younger patients and also leads to a greater number of tumour mutations. and therefore immunotherapy works well in those patients. And that's because largely immunotherapy works by stimulating the immune system to attack cancer cells. And what cancers have done is that they have managed to evade the immune system by tricking the immune system and putting up on their cell surface antennae or receptors that switch the immune system off. They tell the immune system that they're normal cells, and the immune system therefore sees them as normal and doesn't destroy them. And what immunotherapy does is it blocks that pathway. So it sticks onto those antennae, and therefore the immune system isn't switched off by the cancer cells anymore, and the immune system can destroy those cancer cells. The side effects are very different than chemotherapy treatment, and they tend to involve side effects due to overstimulation of the immune system. So you get an inflammatory response in various organs, which tends to settle down with steroids. So steroids are used quite commonly to reduce side effects from immunotherapy. And the final thing I'd like to talk about, which is also commonly asked about now, because patients read a lot about treatments, is about molecular profiling. And that is where, in addition to the few genes that I've talked about, we can now screen for several hundred genes, of which some of them are relevant to treatment. And that's really the key for individualized therapy. So treating a patient not really based on where the tumors come from, but based on the genetics of the tumor. And that's to identify a target mutation, which has probably led to the development of the tumor, and identifying if there is a drug that can target that mutation. And that's being done more and more now, both within clinical trials and perhaps in patients who've exhausted standard therapies to try and identify novel targets for treatment. So that's a short overview of drug treatments for bowel cancer, and I'll hand over to Faye.
Hi, thank you. So I'm the colorectal nurse at King Edward VII, and I'll just explain my role, which is being there for the patient, basically, and making sure the consultants listen to me. But I think it's being there ideally from diagnosis, so the patient can kind of immediately start having a relationship with me, and also me knowing them, and then seeing them. So at King Edward VII, we do a COVID swab 2 days before, which is probably the same in the NHS. And I try and always meet the patient there, because if I haven't seen them before that, I'll have spoken to them on the phone. So it's nice to put a face to a voice that they'll have been speaking to. And then I see them daily while they're an inpatient, and then follow them up as an outpatient as well with telephone calls. And depending on their locality, they'll come and see me in outpatient clinic as well. And obviously it all depends on what surgery they've had and things like that. But I work as a stoma nurse as well. So if they've had a stoma formed, I do counselling beforehand, cite the patient for the best position of the stoma before their surgery, because that's really important to how it's managed post-operatively. And then referring the patient to their local stoma nurse for ongoing support after they've been discharged. And I'm always contactable via telephone and email long after they've been discharged as well. I get WhatsApp of pictures just being like, is this normal on my wound, and things like that, and just being there for the patients really. And then I love enhanced recovery after surgery. So this is based on evidence-based practice, years of evidence-based practice. And so I try and make sure that the key components of that are followed pre and post-operatively. So reduced fasting before the surgery, patient information before the surgery, so they feel more informed and less anxious about coming in for their operation. Reducing their opioid use, their strong painkillers. So we do usually a spinal injection, which helps reduce the need for that post-operatively. And then we do early mobilization and early nutrition as well. So there's, you know, historically, you know, years and years ago, people would be starved for days after their surgery. And now immediately, you know, get them drinking water, then onto a, you know, cup of tea or whatever, and then onto a light diet and get them eating. And chewing gum, because that wakes up the bowel, supposedly helps wake up the bowel after surgery. And then also I help run the FIT service at FIT testing service at King Edward's. So I think James mentioned it. It's a Poo Test that you do at home in the comfort of your own home. You can get it from your GP. There's regular screenings from, I think it's age 50. And then you can also buy them from King Edward's or many companies online. And they're about 50 quid, and it gets posted to you. You get to poo in the privacy of your own home, dip a stick into it, send it off in the post, and then you get a telephone assessment with me explaining your result, going through your symptoms, because sometimes even if it has been a negative result, patients are still quite anxious and interested to seeing a consultant for a examination. And then I'm also in the process of setting up a kind of pelvic floor, low anterior resection syndrome clinic, and that's about bowel dysfunction and things like that. A lot of patients following bowel surgery, bowel resections, can have altered bowel habit, and within the NHS, this service is everywhere. So you can see your GP and you can ask to be sent to the continence service, and you'll get to see a nurse there about pelvic floor function, but possibly have biofeedback and everything like that. And that's starting at King Edward's now as well. So yeah, that's about me.
Lovely. Thank you all. Thank you for telling us all about what you do. We've had a few questions in, if that's okay. One of them relates to, you know, reducing your risk of recurrence. So what's the single best piece of advice to reduce your chance of rectal cancer recurrence? And it's open to anyone that can answer it.
Well, I'll start. I mean, I think so there's some really good advice for reducing your risk of bowel cancer. Typically, we would recommend low-dose aspirin, and but the most important thing really is thinking about your lifestyle, your gut health in general, and that really means looking at your diet. And typically what we would recommend is that you exercise regularly, you lose weight if you're a little bit overweight. That means stopping smoking, moderating your alcohol intake. And it also means thinking quite carefully about your nutrition and your diet. And that's a broader kind of gut health thing. So usually that means high fiber. The recommended daily allowance for fiber in the United Kingdom is about 30 grams a day. To put that into perspective, that's quite a lot of fiber. There's about 2 grams in an apple. And if you've had bowel surgery, that can be quite challenging because your gut function will change quite a lot afterwards, and actually consuming that amount of fiber is sometimes quite difficult. But certainly you can work with a dietitian or a nutritionist, and certainly that's what we do at King Edward's, and it's what I do in my NHS practice too, to try and help you get the level of fiber that you need. And fiber is important because it is anti-inflammatory and it's anti-carcinogenic. But it's also about reducing the things in your diet and your lifestyle which might be pro-inflammatory or might increase your cancer risk. So that means high-fat foods. It means foods that are either rich in processed meats, and also reducing the amount of red meat that you consume. And these things generally will certainly reduce your risk. Of course, there's other more practical things. So you will, and you should be on a long-term surveillance structured plan with your clinical team. And that means you're going to have regular blood tests, regular scans, and also follow endoscopy and colonoscopy to make sure that if something does happen, we detect it and pick it up early.
And I'm sorry, I was going to add to that. Listen to your bowels as well. Although obviously you might have a change in bowel habit after your operation, you can still monitor your bowels and again be bowel wary. You know, again, like we were at the beginning, any changes you need to note and listen to. So a lot of what you're doing in terms of lifestyle and stuff is helpful and makes you feel like you're empowered in what you're doing. But adhering to the adherence program, there's been lots of studies into what we should be doing. And this is why we regularly monitor you, scan you, scope you, and you interpreting those symptoms and being regularly followed up is really important as part of that. Sorry.
Sorry, James, you mentioned about the Aspirin Daily. I thought that was just for Lynch. Is that recommended for all bowel cancer patients?
You're quite right. It is typically recommended for Lynch. You're absolutely right. I have to say, I do recommend to my patients that they go onto low-dose aspirin. I don't know what you do, Charlie, but to me, it's intuitive and makes sense. But there's a number of trials at the moment running actually that will hopefully answer that question for us in the near future.
Okay. No, thank you.
I'll just add that, I mean, the most important thing is to have a good operation and to have the right adjuvant treatment or neoadjuvant treatment.
Yeah, no, absolutely. No, thank you. And with going back to, I guess, lifestyle, so we talked about sort of young patients getting bowel cancer. And I think when there was a lot of press about it, not so long ago, there was a lot of young people who had bowel cancer that felt a little bit offended, so almost being accused of having unhealthy lifestyle. So why is there must be other reasons as well why bowel cancer, particularly rectal cancer in women, is on the increase, and is that related to the gut microbiome?
So shall I have a go answering that? I'm sure Dan and Charlie and Faye will have views on this. So the honest answer is, at the moment, we don't know why young people are having higher rates of bowel cancer. And what we do know is that bowel cancer is a Western disease, right? So if you live in rural Africa, sub-Saharan Africa, the rates of bowel cancer are extremely low. And part of the reason that it's low is because their diet is fundamentally different, but their lifestyle is fundamentally different. But there are also kind of obvious other broader differences, which is that they don't live in, or they're less likely to live in an urban environment. The microbiome is, well, it describes the sum total of bacteria, but also all microbiota, which means viruses, yeast, parasites, and all of the things that they need to survive that live within your gut. And the thing about the microbiome is that it's highly dynamic and it changes throughout your entire lifestyle. And you can think of it like a really big metabolic engine. It's like the only bigger metabolic organ you have in your body is the liver, and it's highly active, and it sits between what you eat and the diet that you have and all of the things that you experience in your environment and your gut. And it is really important in determining the health of your gut in lots of different ways. What we think is probably happening is that the gut microbiome is probably changing, and it's changing quite quickly over a short period of time, maybe 30 to 40 years. And the changes that are really happening are probably happening very early in life. Again, this is all theoretical. We don't have good data to support this at the moment. But certainly what I think and what young people are being set on a trajectory with what you might call an unhealthy microbiome, probably by the age of 3. And then once they live in that Western culture and they have a Westernized diet and they live in an urban environment and they are exposed to many, many different environmental stimuli that trigger cancer, over time that leads to a higher cancer risk. There are a number of different really big studies at the moment trying to answer that question, looking within young people and following them longitudinally. And it's going to take us a bit of a time to unpick it. But the one thing that I would say, because I want to really finish on a positive note, which is that if you're a young person, you can absolutely reduce your bowel cancer risk. Right, and you can do that meaningfully by changing your lifestyle. And again, I'm, fiber, right? It's just so important for lots of reasons. And we've done studies comparing people in North America with rural Africans, and we've done quite interesting studies where we cross over their diet. And within 2 weeks of moving on to a high fiber diet, you see very dramatic changes in the health of the gut. You see dramatic drop off in low grade inflammation. And African people don't get adenomas. I mean, that's obviously a bit of a generalization, but rural Africans in sub-Saharan Africa very, very rarely get polyps. They very, very rarely get bowel cancer. So eat lots and lots of fiber, reduce the amount of junk food that you eat, the amount of processed food that you eat, exercise regularly, don't smoke, moderate your alcohol. It may make for a slightly less interesting life, but I promise you you'll be healthier.
No, thank you. I think one of the big challenges, when I've been harping on about fibre a lot recently as well, and trying to get people to inspire them to share fibre recipes and all that sort of thing, but one of the things a lot of the bowel cancer community say is that difficulty of increasing their fibre, and they generally want to increase their fibre. They know what they have to do, but it can be so difficult. And there's times myself I've experienced, like I have a reasonably high fibre diet, but there are some weeks where it's not working for me. And access, you know, I hear what you're saying about dietitian and access to that, but it's not always possible. Is there anything generic in terms of better to have soluble fibre? I mean, often that's what I say to people, soluble fibre would be better than the insoluble. Oh, you're on mute. Sorry, you're on mute, James.
I didn't. There you go. So my fault. So the thing you have to remember is your colon or your gut or your large bowel is a giant fermenting engine, and it's designed to metabolize fiber. When you have surgery, you lose a bit of that, and so your ability to metabolize fiber in the same way is fundamentally changed after surgery, and it can be very difficult to handle a high fiber diet in the post-operative phase. I think what you can say is that it's okay to take fiber supplements, and you can take supplements which you can get buy at most, health food shops, and certainly they work. We have a trial actually running at the moment in Alaska, looking at native Alaskan people who have very low fiber diets, and they just won't eat it. So we're trialing them with fiber supplements, and they can be a bit easier to manage. So that is something to consider.
Okay, no, that's great, thank you. I've had a few people ask me, can stress cause bowel cancer?
Dan, Charlie?
Oh.
I think ultimately cancer is a illness or a disease of genetic instability, and all the things that James has mentioned in terms of risk factors would lead to damage to DNA and therefore development of cancer. I think stress has long been proposed to predispose to cancer, and I think there probably is a mechanism, and I think that mechanism has to be related to the immune system, and that when you're under stress the immune system is suppressed. And we know from other things that will cause immunosuppression that does lead to an increased risk of cancer. So I think prolonged stress leads to immunosuppression, leads to an increased risk of cancer development. But patients will often attribute the development of their cancer to being under stress. And in reality, particularly with bowel cancer, the development of bowel cancer has been many years coming before it's diagnosed. So somebody who said, well, I've been stressed for the last 6 months, is that why I got bowel cancer? I think the answer is no. But certainly stress can lead to immunosuppression, can lead to cancer.
Well, my research was actually looking at cell-mediated. So there are different types of immune system, and the cell-mediated immune system is suppressed in patients even with bowel cancer. And we looked at, it's interesting, it's the same type of immune suppression you get after surgery, and looking at so that's one of the benefits potentially of doing the operations keyhole is that you minimize that stress response at a time when you're stirring up all the tumor cells. But again, the same thing, I agree with what Dan's saying about sort of stress and low level inflammation, all these things, they contribute to it, but ultimately it's still there's a multitude of genetic variants that lead to it. And all these things, again, that James is talking about, the gut microbiome, there are certain patients who genetically are at higher risk than others, but a lot of it's sporadic as well. So, having a good lifestyle can reduce the risk, but it won't completely eradicate that risk.
No, that's great, thank you. And there's quite a few questions about recurrence here. And one of them is, if you're clear of cancer, is there a recognised time after being given the all clear, such as 2 years later, that it's most likely to try and not come back? So when is that time when your risk sort of drops off a bit?
Well, 2 years is where we start being a bit more relaxed about observation and monitoring. And that's because around 80% of bowel cancers, if they're to come back, will come back within the first 2 years. We follow people up to 5 years, but it drops off, dramatically after 3, 4, 5 years.
Yeah, no, that's absolutely. And that's why I had a big celebration. I hit that mark, and it's actually a massive weight off your shoulders when you hit that mark, because you feel you can breathe a bit longer, but in between you're always having sort of 6 month scans, and it's a bit, you feel left dry a bit though when they say, well, your next scan's in a year's time, and you're like, oh God, I just feel like I've been dropped again. But actually it's something that we should just kind of go, actually, I can breathe a bit more now. The other question, if I can just find it here, was about, where was it? Can any of the doctors comment on the significance of venous invasion versus spread, lymphatic spread, and the impact on likelihood or recurrence?
So I'm happy to speak on that. So we've had a number of different trials in the United Kingdom that have looked at magnetic resonance imaging, or MRI scans, in predicting recurrence in cancer. And a lot of that work's been led by researchers at the Royal Marsden. There's a particular radiologist there called Gina Brown. And when used in that way, EMVI is a very strong predictor of outcome. And we increasingly rely on it for treatment stratification. We also are obviously able to measure it histologically as well. So that means we look at it in the sample and the specimen after it's been removed, and it's an important prognostic indicator. I think what I would say is that typically when we make decisions about treatment stratification, so what type of medicines you're going to have based on your biology, we typically make that based on a number of different features. So it's not just one. We'll look at, you know, somewhere between 5 to 10 different histological features, and increasingly we look at genetics and molecular biology. So it is a very important biomarker, and I would say, you know, if you speak to the evangelists about EMVI, Gina will tell you it's, you know, more important than lymph node invasion. But I would also say that is not necessarily a widely held belief throughout the oncological community, and we will always make, you know, decisions based on a number of different biomarkers.
Brilliant, thank you. That's great. And another question, I'm 2 years clear and 1 year post stoma reversal. Should I be really worried by really foul smelling wind? And I've had this from someone else as well. My scan showed no evidence of disease recently.
Sounds like one for the surgeons.
Well, so the short answer is no, you shouldn't. And it comes back down to everything that I was talking about before. So when you have your surgery, your gut function has really changed dramatically. I think I should also, by the way, say congratulations, by the way, on getting 2 years post. That's awesome. And I'm really pleased to hear you're doing so well. So your gut will completely change, and that fermenting engine that I talked to you about before, its function will completely change, particularly if you've had an ileostomy reversal. And what we know is that function sometimes never goes back to how it was prior to surgery. And that's kind of common sense because a bit of your bowel has been physically removed. But it's also because you've had drugs and medicines and your lifestyle has changed and your diet has probably changed. And so it's quite sensitive to what you put into that system. So if you even change your diet a little bit, you may well change you know, your gut function a little bit, and you might also produce a bit more gas because the type of bugs that you have in there are producing more hydrogen, all right, which is a byproduct again of typically fiber metabolism. So it might be that the bugs have changed, it might be your diet has changed, it might be because the structure of your gut has changed. Having said all of that, if you're worried, go and ask your oncologist and go and ask your surgeon and just say, look, I'm worried, and have a chat with them and get them to see you, because they will know you best, and there's no problem in it. They're always going to be happy to speak to you.
Lovely, thank you. And does the panel have any views on CBD, or Dan, that might be for you?
So the official answer is no. I think, look, the data is not there in terms of CBD oil and anti-cancer effect. And that's why I say to patients that there is just not the data to say whether it has an anti-cancer effect. But many of my patients take CBD oil for lots of different reasons. And I think certainly patients find it helpful for pain control, for general well-being, and for appetite stimulation. So, you know, I'm sure that there are benefits to CBD oil. I'm not convinced that they are anti-cancer benefits, but symptom control and general well-being, I think that there is something in it.
Yeah, no, absolutely. I mean, my mum turned up on the ward with a vial of CBD oil post-op. I was a bit put out considering I was being drip fed morphine. I was like, I think I'll pass on that. But actually in chemo, I actually succumb to it in the end, because I was just feeling so rough. I wasn't sleeping. You get to an anxious state. I mean, if anything, it just took the edge off of things and just helped for a little bit. But it wasn't, as I say, yeah, it wasn't something that I took regularly, but I did try it as well. You try anything when you're really, really rough.
Did it make you sleep better?
Yes, it did. And actually, I got half of my school friends taking it as well, because they just all thought they'd have a go as well. So
I think that's interesting, because I think what is really important is sleep hygiene.
Yeah.
Like resting and properly sleeping is really hard in the modern world, and particularly once, if you're on chemo and you've had surgery and you're stressed and you're worried. Actually, we do know that your sleep, your circadian rhythm, your ability to sleep is important actually for regulating your immune system, just like Charlie was describing before. So Dan is right. The official line is no. There's no evidence that it has any massive impact. But it then if it makes you feel better, it's not harmful. If it makes you sleep, I don't think there's any problem with it. And if my patients take it, I'd say, yeah, have a go. And if it makes you feel better, that's fine.
Yeah,
we often get asked if we can prescribe it, but we can't.
Have you noticed James's background?
Yes.
In fields of it.
Exactly right.
And there's another one for Dan. For what hope is there for a new chemo treatment for the KRAS mutation?
Yeah, so there are trials looking at drugs targeting KRAS mutations. KRAS mutations are common in lots of different cancers, pancreas cancer, lung cancer. The challenge is that there are many different types of KRAS mutations, and the drugs that are being developed are targeting some, but not yet others. Until recently, there was just KRAS. We now have NRAS, and we have different forms of KRAS mutations. So it's not going to be one drug to treat KRAS mutations, or it's going to be several different ones to target whichever one might be present. And those trials are ongoing.
Yeah, no, that's great. Thank you. And my dad is 89 and recently diagnosed a cancer in the colon. The consultant said they would not do chemo, but Anisha said she had chemo. Is this difference due to age? Dan?
Well, there's no doubt that as patients get older, they tolerate chemotherapy less well. But we don't base the decision to give chemotherapy or not based on age on its own. I've given chemotherapy to a 96-year-old, but that 96-year-old was fit and out and about and bowling. And I've had 60-year-olds who I wouldn't give chemotherapy to because they weren't fit. So the decision not to give chemotherapy shouldn't be based on age alone. It should be based on patient's fitness, what you might achieve by giving that patient chemotherapy, and obviously patient wishes.
And I definitely say what they can tolerate, because it was, as someone who was fit and active and having that chemo, it's not easy. And hence the CBD oil, as cycles go on, it gets tougher and tougher and you get weaker and weaker. And this is a question that's quite important. I was due to have my 2-yearly blood stool tests, so I imagine screening in the next couple of months, but on inquiry I've been told that because of COVID, I will not be able to have that test until probably the end of this year. I mean, screening should still be happening and is happening. And I think sorry, I've just butted in there, but I would challenge that and say that it is happening. It shouldn't have stopped. And the fit testing for screening is still ongoing for all patients. And we're still receiving them in general practice, all the results right now. What is in your opinion, is one of the questions, is better, open surgery, robotic, or laparoscopic?
Well, I obviously voiced my opinion quite early. I think the thing is, so it's not as clear cut as which is the best one for you, and that is dependent on what is, whether you've had lots of operations before, because sometimes trying to do surgery, if you've already got lots of scar tissue, makes a keyhole operation very difficult. If you've got a really difficult, complex cancer that's stuck onto more than one bit of the body, then again, it might be necessary to do it as a big open operation. If you can have it as a keyhole one, there's been clear evidence from sort of studies from over a long period of time that minimally invasive surgery improves your sort of recovery in the short term, reduces risk of sort of wound infections, length of stay, and all of that, is a benefit. And then I mentioned this sort of two relatively recent studies kind of questioning the oncological specimen quality on certain types of bowel cancer surgery. And, for me, the robot offers the benefits of both in terms of being able to do precision surgery, but also being a keyhole so you recover well. But, if you've got a surgeon who's an expert in doing open surgery, they're going to do the best job for you. And whilst you might spend a few more days in hospital, the most important thing is the long term is your recovery in terms of you're not getting recurrent cancer and also having good function and quality afterwards. Now, there are lots of the UK, the number of surgeons doing it keyhole laparoscopically has massively increased since the 2000s. And there are loads of expert surgeons who do it laparoscopically. And I certainly wouldn't, if you have a good surgeon, you put faith in them, go with them. But obviously robotic colorectal surgery is the next big wave of surgery that's happening in the UK. Myself and Mr. Misovich, who's also works at King of the Seven, we train surgeons all the time across the country how to do it. And it's certainly where everyone wants to be evolving their practice too, because, technology helps you do really difficult things. But it's still only a piece of kit, and it's only good as the surgeon operating with it. And if you've got someone who's dangerous with a robot, they're going to be dangerous. It's more dangerous than them doing open surgery. So you've got to choose the surgeon and their team, and my team includes Faye, Dan, everyone, is the most important thing for you. And that's more important probably than which type of procedure they do in terms of open laparoscopic or robotic.
That's lovely, thank you. And is your chance of a successful stoma reversal dependent on the amount of time you've had the stoma? So someone's had theirs for 2 years now, but their reversal was cancelled twice due to COVID and is concerned.
Short answer, no, it's not. I'm really sorry that your cancer's been delayed. Your reversal has been delayed. I feel your frustration. It's really frustrating for us as clinicians as well. No, it shouldn't. And sometimes, there's a lot of variance. Sometimes we do early reversals. Sometimes it just takes more time. Not all reversals are straightforward. Some patients require more extensive surgery to do it, of course, because there may be more scar tissue internally. But most of the time, actually, the longer you wait, the easier it is, because all of that scar tissue is matured and the operation becomes technically easier.
Okay, that's great. And
Faye, do you want to say anything on that, because you are stoma expert?
Yeah.
No, I'll just agree with you.
Yeah. Okay.
Oh. And there's been a few people asking about turmeric. What's the role, if any?
Sorry, can you say that again? I didn't hear that. The role of
turmeric. Any benefit of taking turmeric?
We get asked a lot about different herbal treatments, and depending what year it is, it tends to be a different one. I'm very in favor of patients taking these things if that's what they want to do, as long as they are safe. I always give the anecdote of a patient who I looked after with pancreas cancer who responded well to chemotherapy and then took turmeric and remained off chemo for over a year without needing more chemotherapy, which is unusual. The evidence, again, it's not strong evidence-based, certainly no randomized controlled trials, so we can't really answer the question. Scientifically, there's some basis for it, and it certainly won't do people any harm.
What's important? I was going to say, one of the things, when you're a patient... Oh, go on, Dan. I was just going to say...
Go on.
I was just going to say that what it does add is control. Like I often, as soon as I see my patients, we're going to talk about you having surgery and like you're putting your body in our hands. If I give them ideas about how they can, prepare for surgery, you know, work on their lifestyle, what they're eating, even if it's for a short period of time. It's about giving you as the individual some control over what's going on, and I think that's a really positive thing. And what, you know, what Dan's talking about, the turmeric and the cannabis oil, it's about allowing you as individuals not to do any harm to yourself, but allow you to feel a bit more in control of what you're doing. And you know, that's really important, your mindset, because it's such a weird thing to let one of us just take over your body and do stuff to you. And it's a really, you know, it's a humbling thing that you guys have to go through to be, you know, and we might have to go through, you know, in our time, you know, and it's a big deal. It's a lot of it is the psychology of it.
I 100% agree with that. I mean, the loss of control for me, and to be on what I felt was the wrong side of the consult table or the bed is really tricky. And you want any piece of control that you can get, whether that be your diet or your supplements or whatever it is that you try, as long as you're not obviously harming and you've spoken to your oncologist about what you might want to try. So the last question is, again, it's on probiotics. What are the views on probiotics?
I'll have a go at answering that. I'm sure Dan will have a view on it. So that's a difficult question to answer, because it's not entirely as simple as assuming a probiotic is a medicine, for example, which is the same no matter who takes it and how they take it, and it behaves in a very predictable way. So a probiotic is a live bacteria that has an established health benefit. And typically you take it in a yogurt, or you might take it in a capsule, or sometimes you take it in a drink. And they will typically describe a number of different strains in that probiotic, and they will talk about how many colony forming units there are, so the numbers of bacteria. Probiotics have limited evidence to suggest that if you take one, that your risk of getting cancer goes down, or that your risk of cancer coming back after you've had cancer treatment will go down. But there is some evidence that actually they do improve gut function after surgery. And I do commonly prescribe probiotics for my patients in the post-operative phase. Actually, I typically recommend my patients with LARS, so low anterior section syndrome, so patients that have urgency and incontinence, to try kefir. And I typically recommend kefir because it's multi-strain, it's usually got a bunch of sugar in it, and I think it's all the small molecules in kefir that work. And about 30% of them will improve. And that's because LARS is actually a motility problem. It's a gut function problem, I think anyway, I believe. And I think therefore kefir will help. The problem with probiotics, bit of a long-winded answer, very sorry, but it's not a straightforward question, is that all of our guts are so different. So the bugs that are in you are totally different to the bugs that are in me. And if we look at all patients having surgery, there's lots and lots of variation. So it's very difficult to say if you take a generic probiotic, you're going to feel any better, number one. Number two, if you're going to take a probiotic, you've got to take it for at least 4 weeks, because you've got to wait for the bugs to colonize the gut before they have any effect. And number three, if it doesn't work, stop it. It's not going to work after 4 weeks. Stop wasting your money on it, because they're going to be expensive. But if it does work, you've got to keep going. Otherwise, the bugs that are growing in your gut will die off and they'll stop working. So I think as long as, again, it's much like turmeric and it's much like other kind of therapies, as long as you're understanding that they may or may not work and you're happy to take that risk, then I see no problem with them, and I typically recommend them.
Yeah, no, I as a patient, I totally agree with that. I mean, I have the benefit of home of having a gastroenterologist, so it's quite nice. But we have tried with LARS. I mean, it's a whole learning process. There isn't that much information around. There isn't loads of research. It's a really difficult place to navigate, actually. And it's one of the biggest things that a lot of bowel cancer patients tell me about, that is a lot of patients didn't even realize that there was a name for this terminology for these symptoms. Yeah. So we found that 40% of people that were in our community didn't even know that this was a term, LARS, and felt that it hadn't been explained to them, and didn't know how to actually manage it themselves. I totally have gone on probiotics, VSL3, Simprove, whatever, and it does help at times. And the kefir is brilliant. Totally recommend that as well. And yeah, go and we've just tried to get advice, I guess, and pull different information together about what to do in LARS, and trying to get that message out there. But one of the things that repeatedly people ask me after surgery is, where can I get information for LARS? How do I manage it? And the problem with LARS is it's so patient specific. So what is affecting me one week, and I might be stable for a few weeks with my normal gut function, which still might be 12 times a day. Then the next, you know, a week later, it's just gone awry again, you know, and the gut's such a sensitive organ that something after surgery now really upsets it. So it's really difficult to give people that blanket answer as to what helps, but all I guess is giving people the tools to be able to manage their bowel dysfunction a bit better, to give them that quality of life, because it completely changes your life. You know, I remember trying to go back to work thinking, how am I going to consult between patients? What if I need the toilet between like patients? How am I going to manage that? But is there somewhere that you know of, because I haven't managed to find somewhere, that you can get just information on LARS where people can learn the tools or call or anything like that? Because it's definitely a gap in the market that I've seen.
I don't know what Charlie thinks about this. I think part of the problem with LARS is that most doctors, are very bad about talking about it. So we quite commonly don't warn patients preoperatively, but we're also much less sure about how to treat it. So because we don't know how to treat it and how to diagnose it, we don't ask about it, and then we just try and sweep it under the carpet. And of course, you know, as doctors, we feel happy that we've cured a patient of cancer, but we leave patients with really severe symptoms that really dramatically affect their quality of life. And even within the community of surgeons and scientists that do know about LARS, it's still really poorly defined, and we don't have good ways to standardize our measurement and assessment. The Guts charity, I think, had a good section on LARS. I'm very happy to dig that out and to forward it.
That'd be great, thank you.
And there are some patients' leaflets, I know at St. Mark's, that on that as well. Interestingly, like Dan's anecdotal story, like I do see patients who say to me, "Doc, I went to the dentist, and because I had a tooth abscess, they gave me antibiotics, and my LARS went away." Right, and I see that quite a lot, which implies to me that this is all it's all functional. I know also that the NIHR has a big call out at the moment for treatment strategies to prevent LARS, and it's really an emerging field. So trying to get really robust information is actually quite hard, because there basically isn't very much.
But the starting point should definitely be your stoma nurses, your colorectal nurse specialists. That's really important, like for a lot of people, because they're not even doing that. And obviously as surgeons, you know, we are obviously usually onto the next cancer patient. We're not like seeing the LARS patients. That's just the, you know, the volume of work we're working with. So please, if you are struggling with those symptoms, speak to, even if you don't have a stoma anymore, like talk to your stoma nurses, because they're experts on this, and they can offer a lot of stuff that we're not measuring, and they've got, you know, often, you know, our stoma nurses have years of experience of doing this and don't even tell us about it, which is where the evidence is lacking. So they're a wealth of knowledge, even if you haven't got anything you want to read about. Sort of just talk to them.
Faye, is there anywhere else that you could think of to signpost just before we end?
So speaking to your GP, and they can refer you to your continence services, or like they're saying, your local stoma nurses, or I mean, any of your, because you tend to see a team of people when you go into hospital. And then at King Edward's, we're setting up a service as well. So
yeah, I was going to say, come and see us at King Edward VII, and we'll be very happy to see you and help you. Because actually, it's like anything; it needs a multidisciplinary team. And you need lots of different experts, and the treatment is typically multimodal. It's typically a combination of diet, lifestyle, pelvic floor, and sometimes, you know, more invasive treatments. So do reach out if we can help.
That's great. Thank you all so much for all your wonderful answers, and yeah, I think that's been a really enjoyable, informative evening, and this will be recorded, so it has been recorded even, so you will be able to watch it back. If you would like to have a look at the King Edward's website, they've got a website, www.kingedward7th.co.uk, and you can read about the hospital and the charity work that it does too. Any questions that weren't answered tonight, I've been told will be answered via a message or an email. But yes, I'd like to thank everyone for joining us, and see you again soon. All right.
Thank you.
Thanks.
Thank you.